Hello friends, welcome back to Block On. Recently, I got this esteemed opportunity to present the topic of novel techniques of analgesia for knee surgeries at the 4th International ICACON 2023 held at Narayana Health, Bengaluru, which I would like to share with you all today in this video. So without wasting time, let's begin. Knee surgeries vary from minimally invasive arthroscopic procedures to open arthroplasty. Knee replacement is the most commonly performed surgical procedure, but it is associated with moderate to severe pain. Also, the patients are from geriatric age group with multiple comorbid conditions. Hence, such patients should receive the best possible perioperative care along with the most suitable analgesic options, which I am going to focus here. Knee replacement surgeries are commonly performed under neuraxial anesthesia, the safety profile of which is time tested compared to the general anesthesia. With the application of ultrasound, the perioperative analgesic strategies for knee surgeries have undergone a conceptual revolution in the last decade. And with the advent of modern ERAS protocol, we have gradually shifted from central to more peripheral motor sparing blocks to promote early mobilization and to expedite the process of post-operative recovery. So patient needs to be absolutely pain-free to undergo CPM in immediate post-operative period and to work with support after 6 to 8 hours of surgery when the spinal effect wears off. Hence, we need a good working perioperative management protocol, including an effective regional anesthesia technique to support this. It's time to introspect ourselves to find answers for some questions. Are we following up the patient religiously in the postoperative period? Is your patient comfortable and pain free with your pain management protocol? Or are you satisfied with your regional anesthesia technique? In this video, I will walk you through the process by which we developed a novel analgesia technique for knee arthroplasty procedure, that is the dual subsartorial block. All of us were happily performing the adductor canal block until Wang et al. Defined the ultrasound location of the adductor canal. The mid-thigh level injection lateral to the superficial femoral artery, which we were performing, was actually found to be a femoral triangle block. Hence, the benefits claimed in several studies in favor of the adductor canal became invalid, and it was actually due to the femoral triangle block. Next, the researchers started comparing the femoral triangle block with true adductor canal block and concluded that femoral triangle block is causing more quadriceps weakness. Hence, true adductor canal block should be promoted. Now, if you go through the articles carefully, you will find out that the researchers have used either high volume or higher concentration of local anesthetic, which could be the reason for undesirable motor weakness in femoral triangle block. Next, it was found that the true adductor canal block was also not working, and patients with only adductor canal block requires more opioid in the post-operative period. Consequently, we have started searching for more alternatives to supplement with femoral triangle or adductor canal block. In the last few years, if you have noticed, various blocks like IPAC, LIA, Popliteal Plexus block, Anterior Femoral Cutaneous Nerve block or Cuties block, including the medial and the intermediate femoral cutaneous nerve blocks, etc., have been described in the literature. Many of our colleagues even using 5 or 6 blocks, combination of blocks to provide analgesia. It might be fascinating for you, but for me, it's like rampant firing of a machine gun targeting each nerve around the knee joint. We are not against any new blocks. Each one of us is trying to provide procedure specific analgesia in their own way. But where is the evidence? And do we really need them to block separately? The current evidence is not supportive enough. Some studies are glorifying the particular block, but if you do a critical analysis of the paper, you will notice that multiple blocks have been used. Here, using so many regional analgesia techniques and concluding on the basis of first 6 hours observation in favor of one array technique is misleading. IPAC or adductor canal block can also block the genicular nerve of the respective area. So, separately blocking these nerves creates a lot of confounding factors. Similarly, selective blocking of the anterior femoral cutaneous nerves have been described. Again, if you are using femoral triangle block, you don't need to block them separately. The component causing knee pain before and after surgery are different. Before surgery, the knee pain is mainly due to the inflammatory process arising from the pathology inside the knee joint, which is mainly the osteoarthritic changes in the intra-articular structures. But After the surgery, all the intra-articular pain-generating structures, including the richly innervated anterior capsule, are removed and replaced with a non-vascular, non-neural metallic implant. Now, due to the inflammatory changes associated with the surgical dissection at the anteromedial aspect of the knee, the anterior pain component predominates post-operatively than the posterior or intra-articular components. Total knee arthroplasty involves various surgical steps, starting from the incision, extra-articular dissection, and intra-articular resection. It is important to note which pain-generating structures are removed or retained during the surgery to plan for the analgesia strategies. Apart from the surgical steps, we need to understand the post-surgical pain generation process. This is due to the inflammation, microfractures, tendinitis, and the nerve irritation that are associated with the surgical dissections, which causes nociceptions due to the stimulation of the free nerve endings present over the intra-articular and the extra-articular pain generators. The fast pain conducted by the A delta fibers is mainly due to the thermal and mechanical causes, whereas the slow pain conducted by the C fibers are chemically mediated. The neuropathic pain is also an important component of the post-surgical pain, which requires separate group of drugs. So, the pain generation process is a continuous process due to the non-adaptive nature of the pain receptors. Among the various approaches, the medial parapatellar approach is the most commonly used. The midline approach is used for the revision surgery, and the lateral approaches are sometimes needed to correct the severe valgus deformity. All the currently described blocks, including the dual subsartorial block, will not work for other approaches except the medial approach. The complex knee innervation can be divided into two components, anterior and the posterior. Anterior knee is supplied by the lumbar plexus, whereas the posterior knee is supplied by the sacral plexus through their various cutaneous branches, supplying the skin, and the muscular branches supplying the muscles. Anterior group is by femoral nerve, anteromedial by the obturator, and the posterior by the sciatic nerve branches. Many of us still believe that the saphenous nerve is only cutaneous nerve, but that is not true. It has a major osteotomal contribution, as you can see here over the distal femur and the proximal tibia. The infrapatellar branch of the saphenous nerve also give a muscular tweak to the sartorius muscle. Out of the two capsules described, the anterior capsule of the knee joint is richly innervated by various genicular branches of the surrounding nerves. Before supplying the knee joint, these nerves form three different plexuses. The subsartorial plexus lies over the medial side of the knee under the sartorius and supplies the skin over the medial aspect of the knee, medial retinaculum, medial collateral ligament, and the anterior joint capsule. The peripatellar plexus lies around the patella and supplies the skin around the patella, retinaculum, collateral ligament, and the anterior capsule. The popliteal plexus lies over the posterior aspect of the knee joint and supplies the posterior joint capsule along with all the intra-articular structures and retinacula and collateral ligament. Now, let's look at the information we can gather from the cadaveric studies. Here, you can see that the injection of 10 ml of dye in the adductor canal stain the popliteal plexus and the genicular branch of the posterior division of the obturator nerve without coloring the sciatic nerve. In this paper, although it is mentioned as the adductor canal injection, but if you look carefully here, the injection was actually performed at the distal femoral triangle. You will subsequently understand why I am telling this. For example, the apex or the summit of a mountain is also a part of it. Similarly, the apex of the femoral triangle is also a part of the femoral triangle. The important point to note here is 10 ml of dye consistently stained the saphenous nerve, nerve to vastus medialis, and the other cutaneous branches from the femoral nerve. Here, you can observe that the distal femoral triangle injection consistently reaches both saphenous nerve and the nerve to vastus medialis. The distal adductor canal may consistently reach the saphenous nerve only, but spares the nerve to vastus medialis. And one important point is distal femoral triangle injection can involve nerve to vastus intermedius. So you don't need to do that block separately. The injection site and the volume do matter, as well as the concentration of the drug you are using in the patient. More proximal injection with larger injected volume may increase the inclusion of medial femoral cutaneous nerve, intermediate femoral cutaneous nerve, and nerve to vastus medialis. On the contrary, more distal injection in the adductor canal may increase the risk of spread towards the sciatic nerve. Now, coming to our RA technique, that is ultrasound guided dual subsartorial block. Let's understand what exactly we are using in our patients. The first injection is performed at the distal femoral triangle, and the second one is preferably performed at the proximal adductor canal. The local anesthetic is deposited under the sartorius muscle at two different locations. The understanding of the dual subsartorial block depends on the anatomy of the two prominent landmarks in the thigh, that is the femoral triangle and the adductor canal. The femoral triangle is the subfascial space below the inguinal ligament, which lies in the upper third of the thigh. Here you can see two intersecting points. The point B is the intersecting point between the medial border of the sartorius and the medial border of the adductor longus muscle. This point represents the apex of the femoral triangle, which separates the femoral triangle above from the adductor canal below. The adductor canal is about 15 cm long musculoaponeurotic tunnel in the middle third of the thigh, which extends from the apex of the femoral triangle to the adductor hiatus below. It is triangular in cross section, bounded anterolaterally by the vastus medialis muscle, posteromedially by the adductor longus proximally, and adductor magnus muscle distally. Medially, it is bounded by the vasoadductor membrane, which is a strong fibrous membrane joining anterior and the posterior walls. The subsartorial plexus lies in this region, sandwiched between the sartorius and the vasoadductor membrane. The adductor canal consists of three foramina: superior, inferior, and the anterior. Superficial femoral vessels with saphenous nerve enter through the superior foramen, whereas the femoral vessels leave the adductor canal through inferior foramina to become the popliteal vessels. The saphenous nerve and the descending genicular vessels exits the adductor canal through the anterior foramina by piercing the vasoadductor membrane. It is important to note that nerve to vastus medialis always lie outside the adductor canal above the vasoadductor membrane in a separate fascial sleeve. The apex of the femoral triangle can be identified where the medial border of the sartorius muscle and the adductor longus muscle overlies, forming a sign of 3 or kissing sign, as you can see here. The region above the apex is femoral triangle, and the region below the apex is the adductor canal. The prominence of vasoadductor membrane is a peculiarity of this adductor canal region. Nerve to vastus medialis lies above the vasoadductor membrane in the adductor canal region, as you can see here. Due to the varied neurovascular relationship, we can divide the adductor canal into three parts. The proximal adductor canal is just distal to the apex of the femoral triangle. The mid adductor canal is where the descending genicular artery and the saphenous nerve comes out, and the adductor longus muscle is replaced by the adductor magnus muscle. And the distal adductor canal is where the superficial femoral vessel dips into the adductor hiatus to become the popliteal vessels. It is important to note that no nerve lies in the distal and mid adductor canal. Here you can see the bilayering of the lower border of the sartorius muscle due to the presence of this green color vasoadductor membrane. Let's understand the mechanics of dual subsartorial blocks with this simple animation. The first injection is performed at the distalmost part of the femoral triangle, just 1 to 2 cm proximal to the apex. The saphenous nerve here lies lateral to the superficial femoral artery, and NVM lies further laterally in the intermuscular plane between the sartorius and the vastus medialis muscle. Please remember, there is no vasoadductor membrane in the femoral triangle. The saphenous nerve and the nerve to vastus medialis are sometimes separated by the fibrous septa. Hence, we need to perform two separate injections targeting each nerve. Distally, the LA is spread along the adductor canal with superficial femoral vessels under the sartorius muscle, but above the vasoadductor membrane. It involves the subsartorial plexus between the sartorius muscle and the vasoadductor membrane. The proximal spread of local anesthetic involves the intermediate femoral cutaneous nerve, medial retinacular nerve from the nerve to vastus medialis, which contributes to the formation of the medial half of the peripatellar plexus. The second injection is performed 1 to 2 cm distal to the apex of the femoral triangle at the level of proximal adductor canal. At this region, only saphenous nerve lies lateral to the superficial femoral artery. Here, we do not target any nerves directly. As you can see here, the saphenous nerve, nerve to vastus medialis, and the subsartorial plexus are already soaked in the local anesthetic, which we had injected during the distal femoral triangle block. So what is happening here? The local anesthetic that we are injecting here is traveling along the femoral vessels and through the adductor hiatus. It ultimately reaches the posterior region and involves the popliteal plexus. Let's see how to scan for the DSP. You can directly place the high frequency linear transducer over the anteromedial aspect of the thigh and look for the sign of 3. Or you can start scanning from the inguinal region by identifying the femoral vessels and the nerve. By moving the transducer in caudal direction, the apex of the femoral triangle can be identified, where the medial border of the sartorius muscle and the adductor longus muscle overlying, forming a sign of 3. From this point, if we move the ultrasound probe 1 to 2 centimeter above, that is proximally, we will find the distal femoral triangle, where the saphenous nerve lies next to the superficial femoral artery and NVM lies further laterally. And if we go 1 to 2 centimeter distally, we will see the shark head pattern that indicates proximal adductor canal. So the DSP can be performed by following 4 simple steps. Number 1, identify the apex of the femoral triangle by sign of 3. Then perform the first injection, that is at the distal femoral triangle, by identifying the half beak pattern. Here, 5 to 10 mils of local anesthetic is deposited around each nerve. You can also use the nerve stimulator to identify the nerve to vastus medialis. I have uploaded a separate video on the dual subsartorial block technique. You can also watch it from my channel. So that was the first injection at distal femoral triangle. Now, in step 3, you have to again go back to the apex of the femoral triangle. And then in fourth step, we have to perform the second injection at the level of the proximal adductor canal by identifying the shark head pattern. After performing the first injection, if we scan the proximal adductor canal region, you will see the some amount of local anesthetic below the sartorius muscle and around the saphenous nerve, which come from the distal femoral triangle block. Now, we will target the 11 o'clock position first next to the artery, and after hydrodissection, slowly we will insert the needle and place the tip at the 12 o'clock position. The sunset sign indicates the alternative compression and relaxation of the superficial femoral artery during the injection of the local anesthetic, as you can see here. It depicts the deposition of local anesthetic in the correct musculoaponeurotic tunnel. The backflow of local anesthetic from the extension tubing also can act as a surrogate marker that indicates the deposition of local anesthetic in the correct plane. Please avoid higher volume and higher concentration local anesthetic injection at both the levels. It might spread proximally and block the femoral nerve and leads to quadriceps weakness. Volume more than 20 cc in the proximal adductor canal can involve tibial and the common peroneal nerve. Near 40 cc can involve the sciatic nerve in the popliteal fossa. In our experience, DSP is a procedure-specific motor sparing and opioid sparing regional analgesia technique, which provides effective postoperative analgesia when used as an adjunct to multimodal analgesia for all the TKS surgeries, mainly with the medial approaches. DSP provides analgesia over the postoperative pain generating area, as you can see here in the knee joint, by causing complete coverage of the procedure specific pain generating innervations. If you compare with other blocks, the femoral triangle covers the anterior knee pain but not the intra-articular pain. The adductor canal block covers the partial medial knee pain due to the blockade of the saphenous nerve and intra-articular pain due to the popliteal plexus block. By blocking of only popliteal plexus, IPAC only provides the intra-articular analgesia. With the local infiltration analgesia, the pain coverage depends on the technique, agent used, and the sites of the infiltration. The duration is not usually more than 12 to 14 hours. The problem with the LIA is patients usually have severe breakthrough pain once the effect wears off. Other problems are infection, chondrotoxicity due to various agent used, which may lead to joint loosening in the long-term follow-up, and chances of redo surgeries are there. The 4-in-1 block mainly covers the intra-articular pain and may be associated with involvement of the sciatic nerve, which is not required here, and there are chances of sparing of saphenous nerve and nerve to vastus medialis due to the varied anatomy in the distal adductor canal. In our study, we observed the mean pain score remained between 0 to 3.5 till the discharge of the patient, and the mean quadriceps strength remained between 4 to 5 MRC grades. The initial decrease in the first 6 hours was due to the residual effects of the spinal anesthesia. As per our volume comparison study, we found better analgesia with 2010 or 1020 than 1010 volumes. Currently, we are using 2020 volume, that is 20 ml in distal femoral triangle and 20 ml in proximal adductor canal of 0.2% ropivacaine with 4 to 8 milligrams of dexamethasone. Based on our clinical experience of more than 5,000 TKR cases per year, the statistical analysis of our study, and the anatomical correlation, we believe that DSB provides an effective analgesia by covering both the anterior and the posterior knee pain. Please remember, regional analgesia is an essential part of the multimodal analgesia. We need other components too to cover the multifactorial origin of the post-surgical pain to act at various levels of the pain pathway. You need to have a working protocol in place at your setup for the holistic management of the patients undergoing the knee replacement surgeries and modify them according to the patient's comorbid conditions. Post-operative follow-up and assessment of the intensity and location of the pain will help you to understand whether your strategy for pain management or the regional anesthesia or analgesia technique you are choosing is working or not. These are the few pictures from our ongoing cadaveric dye study. I would request you all to kindly go through our publications on the dual subsartorial block for a better understanding. Last but not the least, the whole concept of the DSP was a brainchild of my teacher and current colleague, Dr. Karthik. My sincere thanks to him for giving us this wonderful technique to manage the post-operative pain in patients undergoing knee replacement surgeries. Thank you for listening. I apologize for making a long video. We'll catch you all in the next video. Until then, keep blocking, keep rocking.